corrections, modification, yes?
Just two corrections. One in terms of the date that the department is to present to us. The specifics of the True Shoe and Secure is February 12th, not the 16th. And also in terms of the date of ending punitive segregation for the young adult, it said 6 months to June 1st. It's actually to June 1st, which was a 3-month extension from February 29th. So just a correction of those two dates.
So with that modification, can we have a vote on approving the minutes? All those in favor?
Aye.
Approved unanimously. The first item on the agenda is the update from H&H. And we are pleased and privileged to have with us today the CEO of H&H, terrific guy, Dr. Raju.
Good morning. Thank you very much, Chairman, for the kind introduction and members of the Board of Corrections. And I just want to come here and introduce myself. I'm Dr. Ram Raju, the President and CEO of New York City Health and Hospitals. As you're probably aware, we have taken over the healthcare delivery and the Rikers Island on January 1st. And I'm just here to tell about my philosophy that we'll strive very hard and we'll work very closely with all the partners to give the best healthcare possible. There should not be any difference between the healthcare we deliver at Bellevue and the same type of healthcare should be delivered at Rikers Island. That is exactly what we are striving to achieve in this particular engagement. So I'm looking forward to having more meetings and working with other various partners, Department of Corrections, labor partners, trying to do that the best we can. So thank you for this opportunity, and I am sorry I couldn't stay for the whole meeting because we have a finance committee meeting upstairs going on. As you probably know, we have a real great interest in finance. So, so thank you for this opportunity, and please, and I apologize for leaving the meeting earlier, but hopefully we'll be able to attend the meetings in totality in the future. Thank you very much.
Thank you, Dr. Raju. We and the department and the city are all excited about the takeover of healthcare on the island by H&H. I have to get used to H&H, as I imagine everybody here does. But we are all excited and supportive and just terribly pleased that you and the organization have undertaken for this responsibility.
Thank you, Chairman. Thank you.
The next...
I can give you just a very brief or not. Thanks, Dr. Raju. So I just wanted to update you briefly since November on the transition, and we actually crossed over to January 1 midnight. There was no disruption in service and in care. We, since November, completed screening over 1,200 employees and selected them, qualified, committed, cleared people who had been offered to stay with us beyond December 31st. They were all onboarded in time and scheduled for work, so that was critical to continuity of operations. Also critical was that for every employee whom we asked to join us, we protected their salary, their benefits, their insurance, their pensions, their leave balances, all of which was important to retention. We are now focusing on filling the vacancies that were incurred prior to the transfer, during, and now that we're facing. The fact that we are now with Health and Hospitals has already reaped some benefits in terms of levels of interest on the part of people outside who want to join us and join this mission-driven team, which we're very excited about. Some of the changes we made already in process, structurally, we now have a unified team, a unified management team rather than an oversight agency with a vendor who we had great scrutiny over. So all management from jail site on, up, or down, across, however you view it, are one team in health and hospitals. We have a direct medical, and a direct dental affiliate for frontline staff. We've begun focusing on and created separately to reflect the focus of clinical QA, substance abuse, psychiatric social work as a profession united with discharge planning. And we've begun already leveraging some of the health and hospitals programs in terms of better continuity and reduced likelihood of recidivism after release in terms of hooking up with health and hospitals health home. Metro Plus is now on island, beginning to educate and help families enroll. And we're talking with Gotham Health, which is Health and Hospitals' new, federally qualified health center lookalike, to get people enrolled in and connected to a medical home if they came in without one. So we are looking very much forward in the next few months to few years to getting down to the business that we really are looking forward to, which is the purpose of the transfer.
Any questions? Please.
Well, yes, I have a few questions. Congratulations. And I think the Gotham Health was particularly interesting. I think that's a change in the way HHC has viewed the world, which is not just as outpatient care as a minimalist appendage of the hospitals, but as an important force. And I think that'll be an important referral source for your patients and ours. I wanted to ask, we're going to be discussing it within the board as it goes up, but the suicide of Mr. Angel Perez Rios, recently there are questions raised in the press, and I have questions as well. I've not yet seen the chart, so I've requested it. Appeared that there were delays in his access to mental health services. And I've reviewed access to follow-up care. These are not people these are not the 80,000 people coming in each year who have to be screened. This is not the CPSU where you're going by each day, see if anybody has a problem. These are people who have been identified as having enough of a medical problem that they require follow-up evaluation to see whether they need their treatment, is they're being responsive to the treatment, whether they have abnormal laboratory tests that need to be reviewed with them, whether they are diagnostic tests that have to be ordered and explained to them, whether there are specialty consultations, and my understanding, and in mental health, that they're getting their psychiatric medications reordered in a reasonable time, and they're seeing their therapist. It's my understanding that it's a toss-up at this point, whether someone scheduled for that appointment will actually get there, that it's on the 50% or less number. My sense of the situation is that the department, which previously had movement within the facilities, now is an escort-only jail, the whole jail system, and that escorts have, I believe that one of the major problems, and you know this better than I do, or will know it better than I do, that there's a lack of escorts, and and for whatever other reasons, this is not happening. I wonder if you could describe to us what your sense of this problem is and how it's going to be addressed, and what kind of data is going to be available to us to understand that we have requested information regarding this that we have not yet received. And
regarding this specific, really tragic case, very upsetting, is that I know our department, Corrections, has also initiated its review. Commissioner Pont has agreed to joint agency review, which we're doing this Friday, which I think is critical. I think any incident is an opportunity to improve, to re-examine, to reassess. We are doing this as individual agencies and coming together on Friday to share our findings, see what else we need to find out, and where we can together reduce the likelihood of this recurring. So I don't have the details on this case and the answers at this point in time, except for the fact that we have been, since last 2 Sundays ago, been reviewing our own internal processes and our own data, and coming together on Friday to see what more we can learn.
And on the general topic?
I don't know if the department wants to speak in terms of escorts.
Okay, well, and just in sort of monitoring this issue, do you have the capacity to do this right now? Am I misstating the numbers, do you think? Or?
I don't know. I'm reviewing.
Or understating?
Good morning. So I think that we in the Department of Corrections share a concern about the level of access of patients to the care that they need, particularly for the patients you just referenced, which is patients who come in and we identify as having a health need a specific type of encounter, and then getting them connected with that. I think that we have a large amount of data about the number of appointments we make, the schedule, and who comes to those appointments. I think that what we have found is that as, the security realities in the jails have led to escorted movement and other kind of housing area, led to people being in their housing areas more. We do more work rescheduling appointments or trying to get people a second or a third time. And I think that for us and for the Department of Correction, what we've started to do is engage on really new models of delivering care, so that if people are in places that it's hard to access, maybe we could bring more care to them, and maybe we could ask less of corrections so that we don't give them lists that we all know are too big every morning, or we don't reschedule, ask doctors to spend time rescheduling appointments as a big part of their day. And so those are core issues in terms of access to care. I think that we have good ideas about how to improve on this. And data is certainly a big part of it, but a big part of it is redesigning some of our aspects of care delivery.
On that, there are just two parts. One would be that you're talking about creating they were called mini clinics when I worked on Rikers Island, mini clinics with all the equipment that's needed and confidentiality in a secure way to provide that. And also, if you could address the issue of the effect of lockdowns in housing areas and in entire facilities in providing you access to care, because that's not going to be addressed by these small clinics.
Yeah, so mini clinics are important, particularly in very large buildings where it's hard to move from one side to the other, like AMKC, the West buildings, 17, 18, 19, there's 600 patients in there. And so we actually have, with the Department of Correction, put together multiple mini clinics out there that help those patients not have to move, not have to walk outside. I think, though, that there are other really important features of this care redesign. One of them is, and some of the facilities have innovated on their own already. I don't think that we from the top will have the best ideas. There are some facilities, so in EMTC, for a year and a half, I think actually you heard a little bit from one of the doctors at one of the board meetings, but they have done really great work, the site medical director, the clinic captain there, and the warden, in innovating how to get access to patients on the off hours, the off tours, and the weekends. So types of care that normally would happen during business hours, we've moved resources, us and DOC together, to see those patients when there's less demand, where there might be less security concerns, less movement, less court. I think that also some of the facilities have actually taken PAs and doctors out into housing areas to deliver some care. So at VCBC, that's been a really successful model. I think that, that might not work everywhere. At a big facility where you have to walk a long ways, it might not help. So there are multiple aspects to redesigning the delivery of care. But ultimately, it's that I think the goal is to get patients connected to care more often, and to maybe ask less of the escort, ask for less escort, and make sure that the escort that we ask is for prioritized patients.
Thank you.
Well, Bob, I guess we can pursue this next best after this Friday meeting, and we learn about some of the results, because some generalization may be possible as a bit on the basis of what they learned about this particular case.
We need Homer one more time.
Dr. Winters, you were going to comment on the study, is that?
Yep.
On the study done on alternatives to punitive surgery.
Oh, sure. So we actually, I think 8 months ago maybe, had presented data here about the success of the CAPS program, the Clinical Alternatives to Punitive Segregation. It was sometime over the summer. And so, as we do, when we have data about the success of a program, we don't just share it with you all. We generally will write it up and submit it for peer review, so we can get experts from around the country to tell us, are we doing a good job, or do we interpret this correctly? And so we've probably published 20 or 25 papers like this over the last few years, and this is really the third installment. We had published originally a couple of years ago a paper linking exposure to solitary confinement to self-harm and high lethality self-harm. We then had followed that up and presented data on racial and age disparities in the use of solitary confinement. and the mental health service. And then this third paper really looks at the clinical alternatives to punitive segregation model, this new national, really brand new model that the Department of Corrections and we designed a couple of years ago to replace the Maui, to have, instead of punishment for persons with serious mental illness, a treatment approach in a setting where corrections staff and health staff train together, they work together, they're mutually invested. And what we see in this unit is really dramatic improvements, particularly in this outcome that we've used in all three papers, which is self-harm. So self-harm happens, 500 to 750 times a year in this jail system. Every 100 acts of self-harm result in almost 4,000 hours of escort time needed, 35 or so transfers to higher levels of care. It also results in death. So self-harm is a very serious outcome. And what we see is that when we compare cohorts of patients who have been in solitary settings or restrictive settings to those that were in CAPS, the outcomes are much better in the CAPS unit. And importantly, when we look at the cohort of patients who were in both places, that is to say there's a small group of about 100 patients who were both in CAPS and in restrictive housing unit, those patients were 5 times less likely to self-harm in CAPS than they were in RHU. So, CAPS is expensive. It's very hard to do because of the high level of coordination, but it's been very successful, really through the dedicated effort of the Department of Correction and, their champion, John Gallagher, and many others who have really made this possible. So it's a model that should be used for anyone with serious mental illness in a correctional setting. And as we say in the paper, the high cost and difficulty in implementing it should also make people think twice about the need to incarcerate persons with serious mental illness.
I
Please.
just have a question. Dr. Ventris, I was wondering if there's any lessons, and I've had an opportunity to read your report. Thank you very much. Are there any lessons learned that could be applied to the young adult plan, the housing, the therapeutic services, therapeutic housing, in meeting the challenging behaviors of young adults? Because we know many of them are not diagnosed with serious mental illness, but they're certainly presenting great challenges in terms of safety and security to the inmate and the officers.
Yeah, I think that actually this paper really speaks to that quite precisely, because the cohort of patients, this 100 patients that were both in CAPS and RHU, well, if you were a person who was both in CAPS and RHU, everybody who works in the jails knows that you probably had a lot of behavioral problems, and even though you may have had a serious mental illness designation, you also had a lot of friction, had a lot of problems. And what we see over and over again is that data supports engagement and treatment over punishment. And so for patients who are persistently aggressive, who have persistent behavior problems, we need to figure out secure settings for them. But we also, even in those secure settings, even in the TRU, even in the second chance unit, as we design those units for the young adults, we also have to build in lots of engagement, lots of programs. So the programming isn't just good for the general population, and it's not just good for someone with a psychotic disorder. People with behavioral problems, whatever we call them, do much better with engagement, with programming, and with clinical care.
So the follow-up question is HHC designing some program that could be utilized in these units that will be alternatives to punitive segregation, like the secure unit?
Yes, so Dr. Ford has been working with the Department of Corrections staff on design of the entire young adult program, and I think that it's safe to say that an incentive system is a big part of that, so that everybody knows what the rules are, what are the benefits, what are the downsides to bad behavior. I think that is, an incredibly collaborative process, and we believe, and really it's borne out in where we're at with the planning, that everybody will benefit from knowing what the rules are, from understanding the consequences, and from, importantly, having engagement that's not just clinical care. A lot of people may not need a psychiatrist or a psychologist, but what they need to be is engaged. And so there's a lot of programming that the Department of Corrections provides and will provide in the future that's not clinical care, but it's really as crucial, if not more crucial, to the good outcomes as the mental health care is, which is getting a medicine or getting a certain type of therapy established.
And so in terms of these special units, I know we've had some discussion about this, given the needs of the young adult and the neuroscience of the young adults, do you have any recommendations regarding one of the areas that I know there's still a lot of work being done on, is the basis upon which to place and give notice and any type of opportunity to be heard to the young adults, as well as basis for discharge from these units?
I think that one of the positive aspects to the kind of taking a little more time to think about the unit level plan together is that we need to have a set of rules that everybody in the facility understands, and that has to do with how do you move from general population to any special unit, whatever it is, a mental observation unit, second chance, the TRU, and how do you move back. And to get that set of rules designed on paper, we can do, and I think we have a good start on that. But then to get everybody in the facility to know those rules and follow those rules, not just every health person, but every correctional staff person, people in transportation, the patients themselves, they all have to understand those rules. And so I think that the training and education around these rules is the most important part of implementing this plan.
I read the paper also, and thank you and your colleagues for publishing this work. It is a model nationally. However, when you review the capacity, the number of people in the CAPS unit, there are half as many people in the CAPS unit today as there were a year ago. There are only 21 people there, and 42, I think, a year ago. How can, given the value of this unit, what can be done to increase the utilization?
So I'll check with Dr. Ford, but I believe we're in the middle of, we needed to close one side of the CAPS unit at AMKC to do more training. So every year we have to retrain the staff. These units are incredibly intensive in terms of staffing, knowing the rules, teamwork approach. And so that involves yearly retraining. And so we're undergoing a process where the teams retrain and then we open back up. So we'll be back up to capacity pretty soon. But I think that we do have a design to expand the CAPS model. The CAPS model for the seriously mentally ill, we want to do more of. But we also want to take this and apply it to people who don't have serious mental illness. Because I think that just as the PACE units have really been before the problems happen, equivalent of the CAPS units after the problems happen, we need to build units for people that have lower levels of mental illness to help them not fall into infractions, but also for them to not get sick and not have problems in jail. And so we've been designing with Department of Correction new units that would both be at the PACE and CAPS level for seriously mentally ill folks, but also a greater number of units that would be for folks with a lower level of mental illness. Because you're absolutely right, we need to expand the footprint. This should be our obligation to people with behavioral health problems in the jail, period.
Thank you.
I have a question. To what extent have you looked at some of the inmates who've been in that unit and have sort of released from there, and have they're maintained in general population? Have they been successful in then sort of staying out of CAPS once they've?
One of the difficulties in this, we're getting better at this, but when we built, this is true, you build these special units for the patients who with the most needs. And then they get onto the units and they do very well. Mm-hmm. And then nobody wants to send them anywhere else. And the patients don't want to go anywhere else. So if you look at the cohort in the paper, we've had a couple hundred people come through the CAPS units in the 15-month period that we were looking at data. But many of those patients, our staff did not want, our staff and the patients didn't want to send out to a regular MO, mental observation area, because everybody knew they were going to areas with less resource, fewer resources, fewer coordination. You don't have this great teamwork approach with the security and the health staff. So as we have built the PACE unit, so we now have 3 PACE units open, and the 4th we hope will open very soon. As we have built these mental observation units with the same commitment to staffing, all-day programming, engagement, teamwork, then we have places for the patients to transfer from CAPS into and be maintained actually quite well.
Okay. I think that's an important thing with. We kind of equivalent to what we call a step-down unit, so
yes.
that they're not going from this very structured environment to general pop where there is very little support. So there has to be, I think, an interim. I'm sorry.
Yes, and 2 of the PACE units. One is for patients that are kind of decompensating, might need a higher level of care, and the other PACE unit is for people that have just come back from the hospital. So exactly to your point, we do a good job of finding problems. We sometimes don't have an adequate response in terms of housing area, treatment, security response to effectively manage the problems and the challenges that we've already found. So the PACE units really are committed to do that.
Yeah, thank you.
Please, Jim.
One last question regarding adolescents. I know the department has been challenged by very challenging behavior by adolescents, and certainly violence is up, and inmate-on-inmate fights and some inmate-on-officers. We've had some serious incidences. Is there anything you all are doing to perhaps enhance the therapeutic programming for the adolescents to help reduce the violence?
Well, I think that violence is obviously a very complex issue to dive into. I think that there is quite a bit of violence that is either one-off or kind of what you would call background noise, in that it's not it's a fight that happened between two groups of people, and that fight is over. And that fight disrupts lots of things. Programming, it disrupts security, it disrupts all aspects of life in the jails. Those types of interactions, Second Chance Unit is a good representation of this, where we have a collaborative approach to handling people who have had problems, but we think will be responsive to engagement and treatment. I think that then there is a very small subset, really quite small subset of people who are persistently aggressive. And these, it's unclear, these may be patients, these patients may have clinical issues that are apparent to us. They may have clinical issues that aren't really apparent to us because it's a jail and they're here for short periods of time. And they may have, some mix of behavioral problems that we don't identify as clinical. Those patients, they're small enough in number. We have very coordinated planning with the Department of Corrections. So Dr. Ford, at the highest level, Dr. Ford and senior corrections staff actually have a meeting once a week to discuss the management of this small number of patients, because those patients will always require, they'll always come with very real and serious security concerns. And then it's our obligation to figure out how to engage them clinically as much as we can, keeping the safety of our staff in mind. So I think that for us, what's very important is to discern whether or not patients are in this small group of really persistently aggressive patients, or they're in a group that, has been part of some, violence in jail. That could be a fight, could be, some issue that's a little lower level. It doesn't happen repeatedly. And always challenging ourselves to put people in the greatest level of engagement possible that also meets security needs. I think that's the test we need to ask for every patient.
Thank you. Next is the report from the Department of Corrections. Good morning, Commissioner.
I'll start off on the young adult update. Thank you, everybody. Before I start, just want to also echo thank you to H&H for kind of their efforts in helping us, not just in kind of going through kind of the new correctional model that we're building. It's been a good collaborative effort to start off even before the transition, but particular thanks for the time they've put in for the young adult plan. As the judge was questioning, Dr. Ventners, we've worked a lot, and we've had them kind of at all of our senior meetings, as well as kind of lower level meetings to kind of discuss specific things like policies for Second Chance, what are designed for secure. Overall, as I think we noted in our progress report, we're on pace still to finish all moves of the young adults into GMDC for those that need to be in GMDC by the end of May. We've been working very hard since our last meeting to kind of move that forward. We've been working on the cell repairs, as well as specific changes inside the facility to increase the camera coverage to the ancillary areas. The housing areas are done. We're working on the release of the cell doors. But overall, it's looking good. We're pushing 58% of the population that need to be in GMDC are already in GMDC. Obviously, there are still subpopulations for detox or CAPS or PACE or the city sentence who are going to remain outside. But as of a day or two, we had 517 young adults. There are still about 400 that need to be moved in. The staffing areas, as we start and restart the housing areas, including our potential piloting of Second Chance this month, we'll be steadying those staffs, and with all steady staff, we'll be also ensuring kind of the training necessary, including for all tours having the safe crisis management, and for the as we move forward, we'll be adding dialectical behavioral therapy, which is the CBT, that DC Jackson has promulgated with H&H. We'll be moving towards that training as well for some of the staff. Programming, we have programming available in 10 housing units currently. We're moving forward with adding at least 3 new programming portions. They're proposed, but we need to kind of finalize those, including work with the horticulture program, expanding our ICANN, and also moving forward with a couple other small things with colleges, so for the programming. And then in terms of just a quick update on kind of maintenance, locking functions have been repaired. The manual release and kind of efforts that we have to put in are the remaining repairs that we have to make, and obviously those are a bit time consuming because we've got to move inmates out of housing areas as we repair some of those areas and then move them back in, which kind of builds into where we are with kind of our moves and why we asked for the additional time. But 79% of the housing units have been repaired for kind of their basic plumbing and renovated floors. You know, I think in RNDC we had problems with kind of just cracked floors, so we're making changes to that, and also adding transmitters, Walkmans for the televisions as well. So those are basically an overview of the young adult plan as we stand. You have a more detailed report that came to you last week, but wanted to take an opportunity to at least provide you the highlights and then give any opportunity you might have for questions on that right now.
Yes,
Thank you so much for the progress report and the progress you've made. I'm really seeing substantial progress, and I know you're consulting with many different people to help come up with the best young adult plan possible, and I really do appreciate that. I just have a couple of questions. In terms of the punitive seg, I understand you've opened another punitive seg unit at OBCC for young adults, is that correct?
Yes, we opened an extra house only because as we start moving towards a pilot, second chance, we'll be moving people from either new infractions or from the punitive seg into second chance, but wanted to make sure we didn't get into any type of backlog situation as we moved into the new model.
That was my question, because I know that there's been some problems with not having enough beds and therefore developing a backlog. So I assumed, and I wanted to make sure my assumption was correct, the idea is to have them serve their time.
We didn't want to get to the end date, so to speak, and have, you know, a lot of people waiting. We just want to kind of clean that up and have enough capacity as we move to the new model.
Okay. And is there a plan for what you'll do with that new punitive seg housing unit that's been opened in OBCC for the young adults right now?
Well, eventually we're giving back to OBCC, correct?
Okay. All right, thank you. In terms of punitive seg, I understand that about half of the overrides that were granted regarding punitive seg, whether it be the 7-day or the 60-day, was for young adults. And I've read those. I understand why those overrides are being given, but maybe the chief or whoever would like to address what the challenges are in particular and how you're planning on developing the secure unit to the extent you know to be able to address those needs, because we know it's the cause in which why they're staying in punitive seg so long.
So, yes, the overrides are, you know, for the young adults, and it's just, as you read, it's just behavior-based, right? They engage in activity that usually assaultive behavior that either on another inmate or on staff member, that the override was requested and granted. You want to speak about the second chance?
No, and I think, Judge, I think that's absolutely correct. I think DC Jackson and I have been working on with the group to kind of figure out the entire progression of discipline and incentive, so that doesn't start and end at kind of a secure unit, second chance, but actually progresses from general population in.
And some of the programming that we're focusing on is really focused on violence intervention prevention services, to really focus on those aggressive behaviors that we sometimes see from this population. So some of the things that we're going to implement in these alternatives will include anger management, will include services from service providers who have great experience or expertise working with gang-affiliated youth and really reducing violence. Some of that, those are some
Do you
of the
want
ideas.
to talk a little bit about the tablets and the incentive system? Because
Yeah,
it's all good
absolutely.
news. I'm sure people would love to hear about.
Yeah, so about 2 weeks ago, we recently deployed tablets to the population, both adolescent males and females and young adults, for 2 purposes. One is to serve as, well, 3 purposes. One is to serve as an incentive for those who have been behaving well. Two, is to advance educational opportunities. We also had DOE deploy tablets in their schools as well, so kids can actually finish their homework in their housing area if they have access to the tablets at the time. And we also have it for use as an idleness reduction activity. So kids who are behaving well can go back after school and utilize the tablets to listen to music, watch television, read books. A lot of different options are on the tablet, and they seem to be very, very happy with it so far. Currently, we have about 75 circulating in population between the three facilities. You're welcome.
I have one more question for Jeff. In terms of, I noticed in reading your progress report that most of the escort posts are still not staffed. We've heard this morning about the problems with escorts in general. What's the plan to have those fully staffed so we can make sure the young people get to where they need to be?
So there are two parts to that, ma'am. One is obviously we're moving towards kind of steadying the posts within the housing units. And so that's kind of an effort that we're taking. But once we identify those staff and kind of restart, we'll be moving towards kind of making decisions on how to staff up on the escorts and make sure that we have those in place.
And some of those positions, while we're running them, they're running right now as unfunded, so we have to get funding. Although we are running those positions, we're going to have to get funding to have them as added to the department's table of organization.
So as we added responsibilities and duties to these facilities, we've not gone back and kind of looked at historically, what's the staffing model from the ground up? We'll be doing that at GM, I think, the first facility, kind of from the ground up. What do we need and what posts and where to get a more accurate assessment? Because we've just added kind of on top of the model that was there. And so we want to start from the ground up, but really make a better assessment of that. We'll be doing that in the next couple of weeks. And that'll help us make what resources are really needed.
Just one,
Yes,
one question. Yeah, in terms of, you mentioned DBD training, and I see here that it says it will be conducted by a vendor after procurement is completed. When do you anticipate that would have happening, when getting that staff on board and the training to start?
So there's a couple of things happening. One of the initial principle-based training will begin in February, more towards the end of February, and then the official launch of additional training will begin sometime late March. That's where we are looking at it in terms of estimations from procurement.
Okay.
And that will align with the piloting as we're reporting to you kind of on where we stand. Some of those, that will align.
Other questions?
Thank you very much.
Thank you.
The next item I think to be commented on is administrative segregation.
Good morning.
Morning.
So you want to know about administrative segregation, how we use it in DOC, or is there a question?
Well, I think it would be good to have a description of it
Okay.
as a term, and then how it operates, what does it refer to?
So in New York City, administrative segregation is, for all intents and purposes, general population where inmates get escorted to and from program services. They're entitled to all, or they get all minimum standards. They're locked out 14 hours a day. They have access to all the programs and services, just that they are escorted to and fro. So the housing areas are ordinarily for those individuals who are pending an infraction, waiting to go to punitive segregation, or they have gone to punitive segregation, completed their term, and are now back out into administrative seg, because we don't want to put them into what is true general population. They don't fit the criteria for enhanced supervision housing, and we don't want them in general population because they have shown disruptive behavior that would want us to put extra eyes and ears on what they're doing during the course of the day.
Please.
I know, Chief, that for persons in CPSU, perhaps in ESH, I'm not sure, you have a tracking form where every time, because of concerns that you have and that we share about access to programs in a group like in CPSU, where you record every time recreation is called, every time people go to, how many people go to, independent of the logbook, separate forms on showers, access to law library. Does that form, or should that form cover all people in administrative segregation? And what is it currently, what populations are currently required to be monitored?
So for admin seg, no, because it's an open housing unit. They have access to the showers and all of the program services, just as, if it was a general, if you walked in there, if we didn't tell you it was admin seg, it's operating just as a general population housing unit. Open access to showers, to telephones, we call sick call, they get escorted to sick call. There's no restriction placed upon them.
I know there's no restriction, but the issue here, and there shouldn't be restriction on anyone getting access to those services. So I thought that you had
Right,
recognized
so-
the problem.
Maybe there's an issue I'm not.
I mean, I think, one, yes, we are doing that, as you said. We're trying to move forward with better tracking across Department of Law movement. One of the pilots we're trying to get done, we're moving towards kind of an inmate tracking system using kind of barcode for kind of movement from a housing unit to whatever the program is. We'll start piloting that this year. Unfortunately, we're probably only going to be able to hit a facility or two just because of the infrastructure that is required to do it. But obviously, I think that will help a lot because we won't be relying on kind of logbooks and counting those things, but actually have movement that actually says, okay, from housing unit 1A to law library, back to housing unit 1A, whatever it is. So we'll be working on that, but we believe that we have to go that route.
Thank you.
Yeah.
Chief, you were very responsive to the question. It was just that those, the reason we're concerned about it is because we know that sometimes there's a lack of access to certain programs that occur in people in different administrative segregation settings.
No, we agree, and I
Yes,
think that's why,
yeah,
Jeff,
right.
we as an agency are looking at a tracking system
Yeah.
for everybody.
Some questions. Is there does DOC have a written policy regarding administrative segregation?
There's a section in our inmate housing categories that covers, it's called admin escort, and it just explains basically what I just said. Inmates who are pending an infraction, have exhibited disruptive behavior, but don't rise to the level of pre-hearing detention, or now in this case, enhanced supervision.
Okay, and who makes the decision for the placement in administrative segregation?
So the local warden has the authorization to make a decision, but our Operations Security Intelligence Unit, who also tracks inmates going in and out of punitive segregation and enhanced supervision, they also track admin seg placements.
And I believe you said you all consider it a GP housing unit, and it operates like one, but it's not. And there's
That's
a
correct.
reason you want.
I was
the
just giving an
inmates-
example that there's no, if you walked in and you saw the operation of the house, it looks like a general population housing unit, just that we have additional staff and they're escorted to and fro.
Okay, what's the goal for the inmates that are placed here? Let's just assuming they're coming from punitive seg and they're placed in administrative segregation. What's the goal for those inmates placed in that unit?
The goal is for every inmate to just, comply with policies and behave, right? And if, in that case, in AdSeg, if they comply with that, then we would consider moving them to a general population housing unit. We just want to make sure that those individuals no longer display those attributes that would put them there in the first place.
Okay, and is there a placement review that's something that's set up
No,
systematically to be able to review each inmate that's placed there and determine whether
No.
they still need to be there?
it would be the facility that's housing them. So there is no formal review like enhanced supervision.
Is there determined to be a appropriate length of stay in
No.
this unit?
No.
Is there any type of due process that's afforded in terms of notice and opportunity to be heard as to the placement in this unit?
No, nothing's being taken from them. They're being afforded all services.
I guess just a follow. I'm sorry.
Sure,
Just a
yeah,
follow up
by
to that.
all means.
So, what I'm hearing, Chief, is that there's no systematic review of these inmates that like a period of time, let's say once a week,
No.
during every
You're correct.
30 days. So what would be, what sort of the criteria that you guys determine that somebody would be essentially able now to leave this unit? And how does that arrive?
That-
By whom?
Again, that would be by the facility warden,
Okay.
right? And then they would contact the Operations Security Intelligence Unit, asking for a place for this individual to be removed and placed into a suitable housing unit in general population.
And what other professionals or staff that would be involved in that?
The
Or
housing
would
unit
we-
staff, the supervisors that tour the areas.
Okay. I mean, part of this is my ignorance and just, learning this, so I'm just asking these questions is to get a framework of how, this works. Okay.
Chief, what is the typical inmate reaction when they are informed that they're being moved to administrative section? Do they see it as a detriment? Do they see it
No,
as a
because
positive?
the only thing is they're getting escorted to and from wherever they, once they leave the house, they're getting an escort. Right? They're getting afforded every service that if you were in true, what we say, general population, they're getting all of that. There's no restriction placed upon them. They're getting all their program services. It's just they're getting escorted to and fro, and there's an extra officer in the housing
But do
unit.
they see it as a detrimental move or negative or positive or neutral?
I mean, some would probably see it as neutral. Some would probably see it as a detriment with extra officer in the housing unit, watching what they're doing.
Actually, just for context, there is not a large population that are classified in an administrative seg housing. There are only about 100 there, and because of the mandatory kind of population as well, there's only about 100.
It's a little more complicated than that. I mean, when I go to EdSeg units, I'm always asked by someone, I don't know why I'm here, nobody told me why I'm supposed to be here, why am I here? And I ask the staff and they say, yes, he's here, there's no process to it. Brooklyn House of Detention, you had an EdSeg unit there. According to the warden, it created, that unit was substantially responsible for failure to provide fundamental services to everybody else in the institution because of the requirements of it. So we're concerned about, I think particularly the elements that Judge Hamill was talking about, which is that, and how do people get in? How do they get out? And are services being delivered? Because everybody gets escorted everywhere in every facility right now in Rikers Island. And there's something different about administrative segregation. And I guess we're trying to characterize it a little better, and would appreciate your helping us understand what the differences are, because we know that there are, but you know much more clearly.
I just have a few. The administrative seg I'm most familiar with is the young adult administrative seg that's in GMDC, and I know I've raised this at other meetings, but I'd like to kind of know how the decisions are made then. We know that that's the unit where Officer Calderon was viciously slashed by 2 young adults. We know that's the unit that went through various modified lockdowns. Because these are young people or an administrative seg coming out of punitive seg, they're at greater risk for violence. We know that that's the unit, although it's not set up to be a restricted unit, according to what you're saying. I know that it's the unit where lots of things are denied. And so my question is, and an example is, apparently one day, April, a year ago, a determination was made that they weren't going to have congregate recreation, this young adult administrative seg. And another time it was decided that every young adult in that unit was going to have booth visiting, across the board booth visiting. I arrived to visit, they were all up in arms saying, Judge, what happened? Why do we have to visit in booth? No due process hearings for them. And I was told that's because they're in the administrative seg unit. And I know in terms of the young adult, school comes to them. They don't go out to school the way the other young adults do. They don't get to go to the classroom unless that's changed very recently. So there are, in fact, differences. If it's not a unit that's set up where there's placement criteria and discharge criteria and placement review and the like, who's making the decisions in these individual administrative seg units as to when to change visiting or change recreation. Or the other complaint I get a lot is law library, that they don't get to go to law library. So whether it's that the unit is set up restrictively or on any particular day, days, weeks, or months, there's a restriction. That we're trying to sift through to try to determine that. But assuming what you're saying is the case, and we'll do that, who makes that decision? Is that security? Is that the warden?
Well, in that case that you're speaking about from last April, I was in the facility that day and we talked, and we actually corrected it right then and there with the warden. Right? So the warden made that decision in GMDC, right? So that should not have taken place. So those individuals should have gotten congregate recreation. They should have, what was the other thing you said? Booth
Law
visits.
library and the visiting.
And the
All
booth
of a
visits.
sudden,
They
booth
should not have
visiting
gotten
was
booth visits, right?
instituted
Unless
for
they,
everybody.
unless there was something that we could articulate that they conduct that happened to authorize booth visits, but just because you're an admin seg doesn't mean you get booth visits. So.
Thank you.
Other questions? And I think the next item is the discussion with H&H on the restraint policy. Clinic restraint.
I think this is just an update on a order that was put out for clinic inmates who were under enhanced restraints. An original teletype went out. It was a quick reaction to the stabbing of an officer, an officer in the clinic setting. We've worked with H&H since to kind of edit and revise that policy to make sure it's a little clearer, because we wanted to make sure that some of the language, I think in a haste to get it out, kind of misinterpreted, misworded what was going on. But the movement to clinic right now with focused on enhanced restraints, not administrative seg, unless, of course, they are already adjudicated for enhanced restraints, is what the policy is. We've worked with H&H on kind of notifications and what we would do with that. We're in agreement in the language. As Dr. Venton mentioned to me, obviously we'll have to do some training as well to make sure that all staff are kind of in line with that, particularly working with H&H staff to kind of make sure they know kind of the response protocols. But hopefully that at least addresses some of the initial concerns that came out of the teletype.
Question. But perhaps, Dr. Venn, do you have anything to add to that? Or?
Just that we have had a really productive back and forth in editing the teletype and also understanding a little bit more clearly the population of folks that might be subject to this. And so I think that what is important for us and reassuring to us is that the process that currently exists, whereby the Department of Correction has a security concern and they submit to us a request or a piece of paper that says enhanced restraints are required. We do a medical review of the implications of this. This process, which exists today, will continue to be in effect. And so this directive doesn't widen the footprint of people that may be coming into our clinic in these enhanced restraints. That is to say, it's crucially important for us that that the presumption be that most people won't have this, level of restraint in physical exam settings, but that the people who do will have already been presented to us before the heat of the moment, before they show up in clinic. And so that's a crucial understanding for us in this. And then also the editing of the directive so that when a doctor or PA perceives an emergency or really, a real need to do on the small group of folks, a physical exam that is precluded by the presence of shackles, that there be an ability for us not simply to ask for this kind of more rigorous review by an ADW and then a response back in writing, but to have a feature in there where in emergencies or really important clinical situations we can say we need this now. And so those are important features of our discussion, and I think we've really covered most of that ground in the editing of the document and in discussing how we're going to train our staff.
Good question.
Yes, I think in principle, medical care, as president of HHC spoke earlier, for prisoners should be the same as for non-prisoners. And the presumption that someone is going to not require a physical examination is certainly consistent with historical, rotten care for prisoners. Not something that's been the case in New York City, but the notion that someone comes in and they have a complaint, and that does not involve being able to examine their abdomen, being able to examine their extremities, is really a problem. And I'm concerned that the default position here is restraint for this population. The teletype specifically includes CPSU in it, and historically, CPSU prisoners had their own clinic, and they were not examined in restraints there. It seems to me that there is a substantial enhancement in the footprint, as you described, of people who are going to be examined, in a situation where they don't look like patients, they look like violent persons. And just because someone is in CPSU doesn't mean that they are a risk to your staff. So I'm concerned that we are actually looking at something different right now rather than just the same.
So I'll let Jeff speak to the footprint issue. My understanding is you're incorrect, that the process that exists today, which has been in existence for years, which is that if in the small number of instances where there's a security concern, and actually some of these security concerns stem from us. So as you all are aware, assaults on our staff are up over 400% in the last 3 or 4 years. So our staff are incredibly worried about their own personal safety. So we actually have trained our staff for the last couple of years to identify patients that have been persistently aggressive. We go through this process where we think about how can we provide adequate care to them to not miss things, but also to maintain the security of our staff. So the people who have, the process that exists today, whereby we're asked to do an enhanced restraint assessment of a patient, we do that. We're going to continue to do that. My understanding that there won't be any patients coming in these restraints categorically, like without this process having occurred. I do share your concern that patients who have a presumption of needing higher levels of restraint are patients that I worry that we miss physical findings on them. I think that we have to train our staff on how to handle this because we have persistently aggressive patients. It's a small number, and so we should look at what the number is and track. We also have to look at our staff and how do they handle this. I think that the real refining and changing of the directive was to ensure that the pressure and the scrutiny on this process is not left to the line level doctor, because that is the situation in which the doctors, if the pressure is on them to go find an ADW and raise all sorts of drama about getting the patient out of restraints, it's just not going to happen. So we won't hear about the problem because patients won't get the care they need. The discussion with DOC since then has been to come up with a preemptive, to make sure that people are preemptively being reviewed so that we know in the medical record before we see somebody, oh, we already saw this person, this is what you need to worry about. They have a history of liver disease, they have a history of whatever it is. And then also to put in adequate information for us to enable the doctors to seek release of the restraints. But it's not foolproof. We need to really train the doctors and the nurses and everybody in this process. But it's an area of great concern, but it's also, an area that we have had very imperfect practice up to now. So the staff have not known what to do. When you've had a wide variety of practices in the facilities, that hasn't served the patients either. So I don't know what Jeff.
Let me just comment. I apologize for where I misspoke in there. Were you informed the date a month ago that this directive was coming out that was going to have your staff?
We were not, but we very quickly jumped into discussions and high level.
I guess we weren't either.
I think it's possible, Doctor. I think one of the big efforts has been, and Dr. Benners and Patsy have worked very hard. We're instituting kind of training curriculum for non-defense departmental staff as well to address some of these security concerns. The commissioner's been pushing it pretty hard, so we'll get that up so that we have kind of a minimum of those things. So when people come onto post, they actually do understand some of these issues up front, and there are practices, notifications, and protocols that they're aware of, including everything from the basics of just kind of front rate, kind of movement to actually addressing issues in the clinic. So that's an area of concern for us as well, and something I think jointly we can develop.
What about the
process.
CPSU issue, Jeff?
Footprint-wise?
Yeah.
So again, the way that it's written, sir, I don't believe that we are expanding this footprint. I mean, as a context, again, the population for which this teletype would have applied equates to somewhere around 300 and some. I'd have to do the math correctly to give you a real number, but that's just off the top of my head. Generally, those are the populations that are either in punitive SAG and CPSU or under enhanced restraints. There might be a bit more. I have to actually do the math, so excuse me on that. But we don't think the population is growing by this teletype. Teletype simply reaffirms that for those people who we have enhanced restraints and movement, when they get into this situation where we may have to have a call on either security or medical, we discuss it, make that, and have the appropriate staff in place to protect both the medical staff as well as the correctional officers.
I think it's important to do that. Are you talking about, so you're saying people who are in CPSU who are also enhanced restraints, that's the
So it's
category,
not-
or it's people in CPSU who are not in enhanced
I
restraints?
don't want to misspeak with Chief. You want to kind of clarify?
So inmates currently in CPSU report to the clinic in restraints, and then the doctor would ask, and they have the cuffing bars there for those individuals, right? Then it's also those individuals in CPSU who are in enhanced restraints.
When CPSU was in OBCC, were people shackled when they went to see the doctor?
To the cuffing bars, yes. There's cuffing
In
bars
the
in the
mini
clinics.
clinics on the first floor of OBCC?
Yes. And then same setup right now in GRVC. Every cubicle has a cuffing bar, so the inmate is not just free to get up and walk
Okay.
away.
Thank you.
Thank you. Anything additional?
Question on this.
Oh, I'm sorry.
Is there a placement review for those inmates that are on enhanced restraint status?
Sorry?
Is there a placement review or status review?
Yes, every month. This is
Every month,
A monthly
okay.
review. The medical staff is given a list of every individual. So first and foremost, the list goes to medical, or a sheet goes to medical saying they want to place me in enhanced restraints. They do a medical assessment if there is any contraindications for the restraints. And then once an individual is on restraints, every month medical providers are given a list of every individual in that facility, and doctors do a review of those names and tell the department whether they can continue or if there needs to be a modification.
Okay, so I probably wasn't very clear. Does the Department of Correction do the same way you do placement review, let's say in enhanced supervision and punitive seg time? Is there a status review is probably the better term, for those that are on enhanced restraint status periodically?
Yes, it's a 28-day review by the Operations Security Intelligence.
Okay.
Just to follow up on that, I've talked to prisoners in enhanced restraint, and they are not aware of this. And then I've talked to your staff who tell me that they're not present at their hearing in terms of changing their enhanced restraint status. And I've also wonder what's the chance, when people are placed in enhanced restraints, are they ever taken out of enhanced restraint status and put in a non-enhanced restraint status?
Yes, and the inmates have the right to appeal themselves, and they can present new evidence to the Deputy Warden of Security in the facility.
I'll speak to them again. They were not aware of a process that they could engage in the GRVC enhanced restraint. I was there a couple of weeks ago.
Anything additional that the department would like to speak to? Thank you very much. We'll now go to committee reports, and Judge Hamel?
I really don't think there's anything further to report because we just had a thorough conversation with H&H and DOC on their updates. Thank you.
Thank you, Judge. Dr. Cohen?
Yeah, first I just want to say I really appreciate the last discussion. That was very helpful, and I think the process from the time the first teletype was issued to now has been very, very good, and hope we could continue to work that way. So there is a let me just find my notes on this. The Violence Committee has met on a monthly basis. We've met with the Correction Intelligence Bureau. We have met recently to review the utilization of all restricted units, including administrative segregation, and are collecting data. internally about these units, and our monitoring staff are reviewing the access to Board of Corrections standards within these areas, and that is consistent with the vote we had at our last meeting to consider initiation of rulemaking regarding administrative segregation, including issues of due process for all prisoners in restrictive housing areas. Also, just want to mention here, because it's not any place else on the agenda, that I'm a member, just as a member of the PREA committee, which and sexual violence is a subset of violence in the facilities, and was certainly part of our intention to, as our committee was formulated, to address that. This is an area of great concern to everyone. Many members of the board are working very hard, and particularly our staff, to collect information on this. We met recently with the Department of Correction. We met recently with the Bronx DA. We will be meeting with, we've met with many other people. It's important to recognize here that the number of complaints of sexual violence in the facilities is up substantially in calendar year 2016. There are 246 so far in calendar year 16 versus 154 year to date in fiscal year 2015. This is a not quite doubling of the rate. Another issue, which is, I believe, under the purview of the Violence Committee, is the punishment process, and the staff of the Board of Correction has reviewed the overrides that have occurred in the past 3 months, and it's important to note that the average length of stay in solitary confinement for people who had overrides approved during their current incarceration is 234 days. That's how many days they have spent in solitary confinement, which represents 45% of those individuals' time in the Department of Correction, and they're in this particular incarceration. I raised this number because it's consistent with the point I tried to make at our last meeting, that H&H take a special interest in people who receive these overrides, because they are in prolonged solitary confinement. We're not talking about 15 days, we're not talking about 30 days, we're not talking about 60 days, we're talking on average more than 7 months of solitary confinement during this incarceration. And we have previously asked, and we'll hear, sometime in the near future, I'm sure, I know from the department, about enhancing the amount about what the department can do for this population safely, who are spending prolonged periods of time in solitary confinement, in terms of extending the number of hours that they are allowed outside their cell, in terms of providing them with recreation, which is beyond going out into the cold or the wet or the hot in a cage without any equipment, but to actually to people who are spending hundreds of days in solitary confinement to get them the large muscle exercise that they need for their health. We'll continue to monitor this issue. I appreciate the work that the staff of the Board of Correction has done monitoring this area. Thank you.
In regard to that, I think it's clearly our expectation and commitment of the department that part of what they need to be doing relative to this question is to explore and develop alternative housing for individuals.
Yes,
that's
that's
part and parcel of our discussion, and generally accepted by the department as a requirement for going forward.
Right, and I appreciate
that.
I tried to I lied to that. I meant to say the department is we're looking forward to the department's recommendations on that in that area. Thank you.
Any questions of Dr.? Thank you. We have as matters for the board to take up now the matter of continuing variances, necessity for which has policy and rules that have occurred in the recent past through board action. As has become our policy, we allotted some time for public comment on the variance votes that are about to take place. No one has come forth. They are candidly rather uncontroversial on their face, and we will have a public comment period at the conclusion of the business of the board. But we will now move to a discussion and vote on these continuing variances for their discontinuance. Not very good grammar, but the substance is
We know what you meant.
You need a lawyer to deal with that kind of grammar. So, the first item is the minimum standard around the classification of the prisoners commingling special category adolescent city sentence and detainee inmates. Our approach to these things is to have a motion and a second and then any discussion. So could I have a motion?
Move.
There's a second. Discussion? We'll call the question. All those in favor, I'm not going to do the roll call, but just raise your hands clearly one way or the other. All in favor of discontinuing? Is anyone opposed? So for the record, it's unanimous amongst the members who are present here today. The second item is also a classification of prisoners commingling city sentence and detainee of pregnant inmates. Could I have a motion?
Move.
Second? Second. Any discussion?
Discussion.
Yes.
I just asked the department and the Board of Corrections staff to prepare for us for sometime in the near future a discussion regarding the care of pregnant and women who have delivered recently within the department. We haven't talked about this for a while. I'd like to know what how the nursery is or is not functioning. If it's not functioning, what can be done to improve its function? The prenatal care that we're providing, outcomes to the department. H&H can provide that. So, but I will vote in favor of this.
Any further discussion? All those in favor, again, please raise your hands high. Any opposed? Again, for the record, passed unanimously by the members present here today. And the third variance goes to a minimum standard for limited recreation for inmates in the communicable disease units at the West facility. Can I have a motion?
Move.
Second?
Second.
Okay. Discussion? All those in favor? By raising your hands. Any opposed? Once again, for the record, unanimously passed by the board members present. That concludes the business of the board today, except for, as I noted, the public comment period. We have only one person who was asked to speak, and that is Chris Branson.
Good morning.
Good morning.
My name is Chris Branson. I'm a child psychologist at New York University, also a former juvenile offender, and here to tell you about a project I've been working with staff in RNDC at Rikers over the past 15 months. The project's designed to increase safety for both the youth and adults being held there and the staff, and I think it represents reform for both sides, and I think it has a lot of potential. So as we're all well aware, places like Rikers Island prisons are dangerous places. There's lots of violence which can be traumatic for the inmates and for the staff. We also know that most of the inmates there come into these places with pre-existing histories of trauma, violence, child abuse, things like that. Offenders who have trauma have worse outcomes. They're more likely to act out. They're harder to manage in facilities. But the trauma also affects staff. It affects their health, their well-being. It impairs their job performance. It affects the way they treat the inmates. And it can lead to burnout and them leaving the field altogether. And so the goal of our project is to make Rikers Island a trauma-informed organization. And what that means is one where every person on the island, from the frontline staff to the supervisors to the administrators, understand the impact of trauma, and they provide services and supports to respond to trauma and prevent new trauma, again, both for the youth and adults held there and for the staff. And so what we offer trauma treatments for the inmates to help them recover from trauma, to teach them new skills to manage their behavior, and to be able to be accountable so they can rehabilitate, get their lives back on track. We also offer training for the staff so they can understand challenging inmate behavior, give them a set of proven skills for responding to the behavior, being able to de-escalate with words instead of force. And then working with the frontline staff and the leadership to identify other supports the organization will put into place to help respond and address trauma and support the staff and the inmates. So this is an approach. It's been used in other states. It was used statewide in Connecticut. It's been used in multiple states across the country. And trauma-informed is something the Department of Justice supports. The Commissioner of ACS here supports it. So does the Commissioner of Probation. And in the 2 research studies they've done in juvenile detention centers, when they put this into place, it cut down on youth aggression towards staff. It cut down on youth disciplinary infractions. Staff reported feeling safer, more satisfied. Youth reported feeling more satisfied with the services they received. And rates of seclusion and physical restraint plummeted dramatically, even though they made no attempt to ban it. Just providing these skills, these interventions, made that not necessary. But the real reason I believe in this project is not because of research studies, but because of the officers we've been working with and the stories they've told me of how they've been able to de-escalate potential conflicts, prevent coworkers from using force, and prevent youth there from being victimized again. And so we really believe in this project. It's something that we're spreading throughout New York City. We're working with the entire Department of Probation, Center for Community Alternatives, Center for Court Innovation, trying to spread it to all the judges and attorneys. We just wrote a grant to put this in every secure and non-secure detention facility in New York City. And so I would welcome the opportunity to meet with the commissioner and other DOC leadership to talk about ways to expand this project. They've asked about possibly expanding to the facilities serving young adults as well as the women's facility. We would love that opportunity. Thank you very much.
Can I just ask a few questions?
Yes,
What's
please.
the name of your organization?
I work for New York University.
Okay, and your name?
Christopher Branson.
Okay, can you tell us what it is, what the scale of what you're doing in RNDC is right now?
Absolutely. So what we've done so far, we've done initial trainings with all of the frontline staff. So officers, mental health. We trained the new youth counselors that they brought in. We were scheduled to train the supervisors, captains, all that, but that got canceled. And we've been working with a small group. We've trained them really intensively, so now they can help us train everyone. And so what we need is support, because one training is not going to change anyone's, the way you do things. You need that ongoing support, supervision to be able to really put it into place. And so that's where we're at now. We're ready for that. We just, need to get the right people at the table so we can make that happen.
So a couple of follow-up.
Yes.
What is your funding source?
NIH and SAMHSA. And we got a small contract through DOE as well.
And it sounds like you're looking to expand it. What's your current capacity?
Well, we, to expand it, we may need to hire more staff, but we can figure out the funding. I can tell you we'll do it for a lot less than $7 million, that's for sure.
The population you're targeting in terms of gender right now, you mentioned female and males, or are you just looking at females right now, or?
So right now we've been in R&DC, but this approach can be used with women, absolutely.
Okay.
And we would love to expand it to Rosie.
Because you mentioned the state correctional organizations, DOJ. You're familiar with the Resolve program, Federal Bureau of Prisons is doing with trauma? Okay, that's something that they've been doing, and it sounds like a very similar type of program you're doing. All right, and the professionals that are coming in, what type of training do they have? Who are the providers of this training? Yourself? Just you? Okay.
It's me and my colleague, Dr. Carly Bates over there.
Okay.
It's the two of us. Been to Rikers over 20 times in the last year, along with the other 4 agencies we're working with.
Okay.
We get it done.
All right.
Is there a written description of the program that you could share with?
Absolutely, I'd be happy to provide that.
Thank you. Thanks very much.
Thank you, Chris.
Thank you.
Well, that concludes all of our business today. Thank you for coming. Thank you all.
Gerard. Okay, that's my son and husband's middle name. I should know that. You can see, I know you're